and I'm here to interview Derek Griffiths, who has been awarded the Lifetime Achievement Award by the International Continence Society for his dedication to the cause throughout his lifetime. So, hi Derek, pleased to meet you. How did you develop an interest in incontinence?
I joined the staff in Exeter in England a long time ago, and there was a group there doing electrical stimulation for incontinence in the 1960s. And through that I became interested in the urinary tract, and not exactly in incontinence, but in how urine flows.
And now, how long have you been an ICS member, Derek?
Well, I was at the first meeting, which was in Exeter in '71, and if you do a little bit of mathematics, I think that means that I've been a member for 44 years. But I must say, there may have been some lapses when I didn't pay my subscription, I'm not sure.
Okay, well, I'm sure the office can let you know whether you did or not. How has your field of expertise changed during your career, Derek?
Well, I did my thesis in physics on the flow of superfluid helium. And when I moved to Exeter, I changed my field from flow of helium to flow of urine. That was not such a big step. So after doing a lot on the flow of urine through the urethra, I realized that if I was able to understand micturition, or indeed incontinence, that we would have to look at how the bladder behaved. So I did some work on bladder mechanics. And then when I'd done that and thought I understood urodynamics at that stage, tried to apply it in the clinic. And for many years, actually, I did a lot of clinical urodynamics in adults and old people and pediatric patients. But eventually, I thought, really, what we need to understand how the system is controlled. It's a mechanical system. It's behaving this and that way, but we don't really know how it's controlled. So I took up brain imaging to try to understand how the brain was controlling the bladder. So that's how it's changed. It's changed from being a pure physicist studying helium to being a sort of quasi-neuroscientist looking at brain imaging.
What would you say are the key achievements in your career to date?
Well, actually, I think it's mainly more general. It's making people think of of lower urinary tract function rather than just its structure. That's to say, instead of doing surgery, they tend now often to think of doing things which should affect the function of the lower urinary tract. And I think that's been, of course, not just due to us or to me or anything like that, but there's been a general movement away from to always do surgery to try other things first, at least. And I think we've saved a lot of people undergoing unnecessary surgery, and I felt we did that when we were examining pediatric kids, and also when we were thinking about how men with prostatic obstruction, so-called prostatic obstruction, should be treated.
On another track, actually, how has the ICS changed during your tenure as a member?
Well, one obvious thing looking around here is it's bigger. 44 years ago, there were 40 people meeting in a small hotel room in Exeter, and that was the International Continence Society. Now there are apparently 2,400 members of the International Continence Society, and that means its character has changed quite a bit. When it started, it was a group of people who were fairly scientifically oriented. A lot of them were clinicians, but they were registrars and doing research, and they were intimately bound up with research and had quite a scientific attitude. And now, with huge numbers, what I call huge numbers, being members of the ICS, somehow the meeting has changed, and it seems, in fact, it changed from years ago. And for several seasons, I didn't come to the meetings sort of out of protest because I felt they'd become too big, too luxurious, and not academic enough. And I gave up that struggle. I sort of came back into the fold. But I still feel that it shouldn't be too luxurious. It shouldn't be too expensive. It shouldn't be too grand. It should be a scientific meeting.
Thank you, Derek. So I imagine that 44 years ago, you had never imagined that the ICS would grow so large in numbers.
Of course not, no. We thought it would always stay the same as a little group of people.
What changes would you like ICS to implement in the future, if any?
I do wonder if, instead of having one huge meeting, there could be sort of, not splinter groups, but small subgroups operating at a more scientific level to discuss various topics in an atmosphere which it wasn't quite so social and as I say, luxurious. For example, the meetings could be held as they were at the beginning in universities rather than in big hotels, particularly if they were in smaller groups.
What does the ICS Lifetime Achievement Award mean to you, Derek?
Well, to be honest, I think it means more to people who know me than it does to me, because it gives people like my wife an opportunity to think, oh, at least someone appreciates all that work. And it's not just me. So it's something to branch and say, look, other people think this is worthwhile.
A great answer. What advice would you give to trainee early year members just starting out?
Well, the easy answer is I really don't know, because I've just always done what came next. You know, I never made a plan. It just developed. Really, I feel that what you should do is you have to realize that there isn't really a career pathway, for example, in urodynamics. That's not quite true in Britain. There is something now, but most of the world, there's no career pathway. And if you want to make a career in this sort of thing as I've done, as maybe a scientist in a medical surroundings, you have to be prepared to move around, I think, like I did, to make a career, to move from one place to another place where they let you do some clinical urodynamics, and then maybe to another place where they let you do brain imaging or whatever, you know.
Derek, I seem to recall you lived in the Netherlands. You're from England, as you said, Exeter. You lived in the Netherlands, and now for many years you've been in Canada and in Pittsburgh.
I have moved around a terrific amount. I mean, I'm obviously English from my accent, but I spent 10 years in the Netherlands, at least 10 years in America. I can't think how long I've been there. And a similar sort of time in Canada, oscillating between Canada and the US. What I intend to do is to continue working on brain scans from Pittsburgh, and I'm sure that I shall find new things.
That's very interesting, and I really hope you do. And the final question, do you have any additional things or advice that you'd like to add before I pass over to Alex?
Yeah, find the right person to work with, because you'll have to do that, and if you find a good person, you'll do great things.
That's very sage advice, actually.
We've got a few questions from the audience, if you don't mind. The first question is coming from Marcus Drake.
I think it's amazing how many different fields that you've covered in such great depth and bringing such new insight and progress. And now you've moved into brain imaging. It's yet another sort of fantastic development. Now, how do you see this progressing in the foreseeable future? Such a technical challenge, such a fast evolving area.
My feeling always is that you never know what's going to come next. So I don't know how it will develop. I just feel that this is something we don't understand, and it's exciting to work on it and try to find out to increase our understanding. And how it will develop in the future, I have no idea. I mean, at the moment, it's quite clear that this brain imaging stuff, or indeed any studies of the brain, are highly non-translational. I mean, they're entirely scientific. But perhaps in the future, something will happen. For example, the sort of treatments you might consider, if you know more about how brains behave, are deep brain stimulation sort of techniques. Now, it sounds a bit crazy, doesn't it? But perhaps it might be worth it in some people.
The second question comes from Peter Rosier, that you know very well. He's the ICS chair of the Urodynamics Committee.
Hi, Derek. I'm really happy to be able to ask you a question and to put you where you are at ease, I think, and that's in urodynamics. And I feel when I do urodynamics that I'm on your shoulders all day, and on the work that you did pioneering in pressure flow analysis and analysis of voiding and analysis of contraction. Trying to move forward in what you did in contraction. And there's two ways or more ways of analyzing contraction, and that's your method with WF, and that's one of the extrapolation methods. And I think my opinion is that WF max works fairly well in the slow motion voiding of men with outlet obstruction, but does not work very well in women. So, but if you can advise me where to go to with one of the extrapolation methods or with WF or in one of let's say calculation methods, what can you think of?
I think you put your finger on it. It doesn't work. It doesn't work very well for women because the analyses were never set up for women. When I think we have to take much more attention to, well, you call it straining, but anyway, to abdominal events. And so what I would suggest you do is research it. Yeah, just try to find out more, because I don't think we can predict which method of the existing methods will be best, or if any of them are any good at all. You think you should just have to research it.
Thank you, Peter. My next question, I'm sitting in the Urodynamics committee, and recently there was a big debate within the member of the Urodynamics committee, because if we look at the definition of the trusor overactivity as defined by ICS, the trusor overactivity should be defined as any rise of the trusor pressure. Don't you think that we should add in that definition with the presence of symptoms? Because this is the only way I believe we can differentiate physiological versus pathological abnormal detrusor contraction.
The answer to that is I don't really know. I think that you should merely note whether the patient had sensation or not, but I wouldn't throw out the ones where the patient didn't have sensation, or indeed throw out the ones where they did. You know, I would simply suggest you have another parameter. It is what they felt when this was occurring.
This introduces again the next thing that I think we should carry on talking about: interactive urodynamics more than invasive urodynamics. At the presence of a urodynamos at the time of the test is absolutely mandatory. Otherwise, a rise of 4 centimeters of water during the filling phase in the absence of sensation, we, according to the ICS definition, should define as the trusor of activity.
And I still think that's quite reasonable, but if it doesn't have sensation with it, then you shouldn't say it's not. You should simply say it's without sensation, so that you know it's another category. You can see I'm a scientist, and I never make anything simple. I always make it more complicated.
Thank you very much. I think we've done for today. It was a great pleasure and honor for me to interview you.